We're going to get started right now. Welcome. I'm going to let our panelists introduce themselves.
So we have Rebecca and Reb. So just to make sure everybody has that awareness, I'm Rebecca. I grew up in Minnesota and I've been in LA for a dozen years, and I work as a director of addiction and community medicine at Los Angeles County General Hospital, which is a new name for LACUSC. And I had the honor and privilege to work about 10 years as a part of the Department of Emergency Medicine as a family medicine doc, really looking at kind of utilization patterns and how to help get people to where they need to go.
And I'm Reb Close. I did my first life of medicine in emergency medicine, worked in a community emergency room here in Monterey for about 20 years. And then I did the practice pathway for addiction medicine, and I am currently working in our street-based clinic. I do in-reach at the jail, and then I work in an addiction clinic. So I've seen it from the ER side, seen it from the clinic side now, and then kind of still do a lot of crosswork. So that's who I am. And I also have been working a lot in advocacy for the last 11 years, trying to raise awareness and educate the community. So glad to be here. Thank you.
Thank you, Reb and Rebecca. I am Nicole Wojtal. I'm an emergency and addiction medicine doctor based in LA. And thank you so much for everyone here joining us on our webinar on medication for addiction treatment for stimulant use disorder. And I'm going to share my screen. And again, thank you for joining us. This is a super important talk, definitely one of the top 3 topics we are asked to speak about from hospitals and other care teams. If you're not familiar with California Bridge, we are a program within the Public Health Institute, and we're funded by the Department of California Healthcare Services. We're a nonprofit organization. We don't work with any pharmaceutical companies. And however, we will be talking about, we will be saying the name Wellbutrin instead of bupropion. This is just to avoid confusion with buprenorphine, which we talk about a lot. We don't have any brand loyalty. It's just easier to say Wellbutrin instead of buprenorphine, or instead of bupropion. As you can tell, I already made the mistake. If you're not familiar with Bridge, we are trying to make evidence-based treatment available to patients who use drugs, the standard of care in every hospital in California by 2025. We are well on our way with over 270 hospitals. And this goal exists because we know drug overdose is killing way too many people. Overdose is one of the top killers of Americans. And we talk a lot about opioid overdose, and that's with good reason. Opioids cause the vast amount of overdose deaths here in our country, but stimulants like methamphetamine and cocaine are the next highest cause. And when you just look at stimulants, some of those deaths are mixed stimulant and opioids, but a majority are actually simply stimulants alone. This is an interesting partnership between the American College of Medical Toxicology and the Center for Forensic Science Research and Education, and they look together at the role and prevalence of drugs during overdose events. And in the final quarter of 2023, they analyzed about 300 patient samples and tested them for over 1,000 potential drugs. And lo and behold, they saw that fentanyl was the number 1 illicit drug found in patients' serum at the time of overdose. But number 2, that's the blue bar. Number two is methamphetamine. That's the highest red bar. And this specific percentage varies regionally, but the general theme is true that methamphetamine is the 2nd most common drug nationwide associated with drug overdose. So we have to consider and address the stimulant epidemic in our country. Why this is important is, the California Bridge model is here to revolutionize the system of care for people who use drugs. And this holds true for any substance use disorder, including methamphetamine. So we're trying to bring low barrier access to evidence-based medication for addiction treatment. So we want to treat substance use disorder just like any other treatable medical chronic disease that requires meds. We want the meds for substance use disorder to be as easy as getting drugs. So we're working with ERs and acute care teams to make this happen. Additionally, it's critical for our patients to get ongoing outpatient care. So we have to be able to create pathways and connection to outpatient providers, ideally using a substance use navigator or other support system to help patients navigate the complexities of getting outpatient care. And lastly, we're trying to establish a culture of harm reduction. And this is really two parts. One, reducing stigma associated with substance use so our teams can provide better patient-centered, compassionate care, and also learning to talk to our patients about ways to reduce morbidity and mortality associated with substance use. So for stimulants specifically, we have to address the elephant in the room that stigma, there's a massive amount of stigma around stimulant use, specifically methamphetamines. I know in my work as an ER doctor, we carry a lot of negative opinions about patients who use meth. This has been true for decades. It's really hard to overcome. And it seems impossible to talk about how to treat patients who use meth without breaking these stigma-ridden barriers. And it seems like a daunting task. And I'm wondering, Rebecca, can you talk me through what this can look like? Why is this such a tough patient population, and what can we do about it?
Thank you. So one of the important features, and a lot of us here thread both through emergency and acute care settings that have relationships with the court system or the justice system, when we fail to address addiction as a medical issue with really excellent treatment models, a lot of our patients end up with the health harm and the social harm of, arrest, custody, and confinement. And that's, I think a large moral failure of our physician community. So addiction, including stimulant use, is a chronic condition that has excellent medical treatment. And the more we say that to each other, to our patients, to our community, to our judges, to our sheriffs, the more I think that the social treatment of addiction improves, and we can start living in communities we all want to live in. So we can go to our next slide. My practice has really shifted. One of the things that is somewhat unique about stimulants compared to opioids is that when we are intoxicated on stimulants, that's often a very expressive condition. We've seen that agitated delirium in the ER. We've seen that like hyper verbalness of our patients. And often people are telling me a lot of things, and I moved to a place of radical acceptance. So I'm aligning myself with my patients' history, their stories, their presentation, to really understand what's going on. So a lot of times people tell me that they use methamphetamines because, they have ADHD, was never diagnosed. Sometimes it's a behavioral health issue that they feel really depressed, or maybe with the chronic use of methamphetamines, when they're not present anymore, they're really dysphoric. A lot of my patients in Los Angeles, and I'm sure in many of your cities, use methamphetamines to stay awake and alert through, double shifts, triple shifts, working a couple of days in a row so they can send money to their family, or they don't have housing. So, just really having that understanding that these are compassionate, rational reasons. Often by the time they come to us in the ER, it looks really unrational. Like, how can we keep using methamphetamines when you keep having heart attacks? Something like that. And it's hard to see that radical acceptance and align with our patients. So I urge everybody to try this out the next time they see a patient. We can go to the next slide. When we have substance use patterns, and this again, I think of my pediatric patients in the emergency department when I think of unintentional use. So sometimes people come in with overdoses, and they earnestly, honestly, and are accurately self-reporting that they did not intend to take that substance. Maybe it was, some abuse in a relationship, and that person was trying to coerce somebody to do something. Maybe it was somebody who was slipped something at a party. Maybe it was somebody who was actively poisoned or maliciously intent to do something. So I think about human trafficking. I think about sex trafficking, and I think about power dynamics in relationships. When somebody's telling me, I didn't know I had stimulants on board. This isn't an uncommon thing, and often, especially in our pediatric populations, we all have a tendency to minimize use patterns. Our patients have a tendency to minimize use patterns. And often the most modal situation I'm seeing in the acute care setting is somebody with chronic, dependent, or chaotic use. Less often is it experimental, although that sometimes happens, especially in our younger patients. And the social use pattern I'm rarely seeing. Although if you practice perhaps in a private insured clinic where people are showing up on time to visit, then you can understand why you might be seeing somebody who has more of their social features intact in their life and they have a social use pattern. But those are the things I wanted to say, is that really be mindful of, could something be unintentional and therefore indicative of something else? Or are we more likely seeing a chronic, dependent, and chaotic that's being explained as an experimental or a social use? Once somebody's in that chronic use pattern is when I'm really thinking about intervening with medication for addiction treatment. We can go forward.
Rebecca, that was so helpful. One thing I'm wondering is, when in the world am I going to be able to have this conversation with this patient? When I think about patients that use stimulants in the emergency department, they're sweaty, they're agitated, they're psychotic, they're yelling. I just want them to be quiet. So it's super challenging in a lot of ways. And there's certainly no way I'm going to be able to genuinely kind of empathetically explore their story, but I do want to help. Reb, help me here.
Yeah, so you are absolutely right. Having worked in both the ER setting and now in the outpatient setting, I actually see so many patients in various stages of their stimulant use disorder. And so what we came up with as a way to kind of talk about this is how do you approach this patient depending on where they are with their stimulant. So looking at this slide, we kind of pulled it into 3 different phases of stimulant use. Okay, so we have that acute intoxication that we see in the ER, that I see on the street with my patients, right? So we'll talk about that acute stimulant intoxication phase. The second phase is stimulant withdrawal. That has its own withdrawal syndrome that we need to be mindful of, and we can talk about that because it relates to other presentations and needs to be considered when you're working patients up. And then the third phase are the chronic effects of stimulant use. I mean, what's going to happen to these patients in the short-ish term and long term, and what things do you need to look for as a provider so you can treat them for that phase of their stimulant use? So that's how we broke it apart, and I hope that makes sense to people. And so we're going to talk about a little more with each of the stimulants just to kind of get everybody on the same page. So the phases of stimulant use, it really depends some of the information we need to have is based on the dosing timeline, as well as the time of onset and the half-life. Okay, so when we're trying to break it apart into those phases, we also need to have a little bit of this background. And obviously there are a number of stimulants out there, but for those of us in healthcare, meth and cocaine are the big ones that we see, right? And it's just because they're so common in society, they're so easy to get, they're just completely ubiquitous. So we need to consider those because of how commonly we see them. Now, MDMA and ketamine, those are more kind of party drugs, and you'll see them, but you can also consider them as your typical stimulants. But I'm going to focus more on meth and cocaine. And you can see here kind of the time of onset and the half-life needs to be considered when you're figuring out those 3 phases. Okay, so we'll jump forward. We got that in our next slide. Yeah, nope, I missed one. There you go. Yeah, so just to clarify, the route of administration needs to be considered as well. Are they using it IV? Are they smoking it? Are they snorting it? And that helps you with your timeline as well. So whether the effects are immediate and you're seeing it in those first few minutes to hours, and how long you can anticipate the effects are going to last. Okay, sorry, now we'll jump forward. All right, so the acute intoxication, and this is kind of that ER street-based presentation that we see all the time, and you're going to see that anxiety, potentially anger, agitation, violence, exactly what Nicole mentioned. There can be psychotic features with it, hallucinations, delusions. These patients can be really euphoric and really hyperverbal. Sometimes they get a little blunt and almost like they're responding to internal stimuli and not really able to fully engage. But these are some of the things you see in that acutely intoxicated, hyperstimulated state. Okay, I think we're all pretty familiar with it. And when we talk about treatment, this is kind of important. So other things you will see in that acute phase, if we'll go to the next slide, yeah, are the physical changes, right? So we're going to see, these are some of the things you're seeing on exam. They may have dilated pupils. They could be diaphoretic. Some patients will have nausea and vomiting. They may be anorexic, and depending on their use patterns, that may lead to significant weight loss. The one thing we see a lot of as well is the pustules, the skin lesions, the scabbing from the picking. And we see, I will literally see my patients are sitting there talking to me and they're just picking and picking and picking because they're acute intoxication. Additionally, there can be some pretty abnormal vital signs. So you may see tachycardia, bradycardia, hypertension. They may have dysrhythmias. They may have chest pain. So just being aware of that acute state, these are some of the ways that you may see the patient presenting physically. All right, next slide, please. Oh, we got it. All right, and then in the far extremes, you're going to see that significant agitation, violent behavior. These are a lot of the patients that may require chemical and physical restraint. And ultimately, you can see dehydration, rhabdomyolysis. They can have seizures. And you look at this as kind of a stimulant overdose, right? We talk about overdoses all the time with opioids and how those present, but this is a stimulant overdose situation or stimulant poisoning situation. In the past, it was more referred to as excited delirium. We're kind of getting away from that terminology, and it's more of an acute intoxication, the hyperactive delirium with severe agitation. So hopefully that makes sense of kind of that acute stimulant intoxication phase, what they may be presenting with, what you might see on your exam, and how extreme it can get. Okay, so we'll come back to treatment on that in a minute, but let's jump forward and talk about withdrawal. Okay. Stimulant withdrawal, you imagine your dopamine super high, you've been agitated, you've been in this excited, agitated state, and then you crash. And we talk about it as a stimulant washout, or meth crash is kind of a commonly used description, but it is actually a form of withdrawal syndrome. And there's a DSM-5 diagnosis for it, right? So they are profoundly and horridly dysphoric. Okay, the mood is terrible. I mean, you've had your dopamine super high and everything just crashes down. So it's kind of worst case ever. Everything's awful. Nothing's good in this world. That kind of dysphoria. Okay. So we see that, and it is associated with the stimulant withdrawal time. And that goes back to that slide kind of describing the half-lives and when you may see this. So it can be hours to days after they've stopped using stimulants. Additionally, if you think of all the things that we were seeing on that acute intoxication time, this is associated with severe fatigue. They can have really unpleasant dreams. They can be they can have symptoms of hypersomnia, so they just crash and sleep, or they can have trouble with insomnia and really have some fitful or challenges with sleep. Obviously, there can be some appetite changes, and you can see that psychomotor retardation or even some agitation associated with it, but not like we were seeing with that initial really hyperacute phase. So just consider that severe dysphoria and really crashing down from that high stimulant activation. Okay, so I hope that makes sense. Now moving forward into some chronic effects, right? And these are the things that someone will come in for, present with, and they may not say, oh, by the way, I have a stimulant use disorder I've been using for X number of years, and I'm coming in because of these problems. They may present with something else, and when you dig a little deeper, you get more information. You may find out that it is related to their stimulant use that may or may not have been disclosed. So this is, again, the chronic skin changes that we'll see, the itching, the rash. I know we've all seen this where somebody's like perpetually digging at their skin for the bugs or worms or things that they're sensing or that they're afraid they're dealing with in their skin. Psychotic features or truly delusions. They can be dangerous to themselves and others. They can come in on 5150. So that's another thing that you may consider that methamphetamines or other stimulants could be related or could be partly involved. And then obviously people can come in with seizures, other reasons for agitation. All of these things where someone's coming in altered or agitated, it could be associated with stimulant use, and it just may not be something we're actively aware of or that we're seeing that acute intoxication phase clearly. And so on the next slide, please. There we go. Yeah, perfect. Thank you. And then these are some of the things that I'm seeing more in the clinic now, depending on the presentation, but we all obviously see them in the ER as well, is the chronic conditions. So the abscesses, we're seeing a lot of skin breakdown. Obviously, MRSA is super common. Heart failure. I mean, I had a patient the other day that was told, all of your heart problems are related to stimulant use. And so trying to get her into care, into treatment. So yeah, I'm seeing somebody mention they're seeing a lot of CHF. Exactly. So, acute coronary syndrome, CHF, dysrhythmias, obviously pregnancy associated issues, delayed prenatal care, trauma. That's a big part of it as well. We see a lot of people either with assault or being assaulted. That's a big issue that we see with stimulant use as well. Recurrent AMAs or recurrent failure to comply, so to speak, with medications or medical recommendations. This is another thing, kind of that chronic effect of stimulant use that we see really frequently. So I mentioned we have these 3 phases, and I mentioned that we would talk about treatment for those. So Rebecca, you want to kind of launch us into some of the treatment for each of those phases of stimulant use?
Thank you. And we can go forward. One of the things I want to highlight is this can be overlapping and kind of concurrent planning. So a lot of us in that acute care setting are doing, 3 different things at the same time. So the first thing is you're thinking about safety for your patient and safety for your staff, thinking about ways that we can reduce agitation, violence, withdrawal effects that can become explosive to other patients, to other community members, to your staff. So we have implemented the violence checklist brochure. We recommend that there is some structured thing for patients coming in with that acute kind of mood and behavior that it can be really dangerous, and be able to modify those things in addition to the usual care that I think is excellent in all of our emergency departments, which is, are you having a heart attack? Are you having a stroke? Or, how do we give you the supportive care for the stimulant poisoning and the effects that we see? And then really investigating those traumas and thinking about, like, why is this person in a gun violence incident? Is there some underlying use disorder that we can kind of try to key up some treatment with? So we can go to the next thing. So again, I think our ERs are amazing at doing this, heart attack, arrhythmia, CHF, rhabdo causing renal failure, stroke, seizure, sepsis. It's then trying to ensure that these things aren't just supportively cared for and treated acutely, but we address the upstream issues that prevent them from becoming a recurrent issue and help this person live a well life. So we can go forward. One of the best things, this is, a lot of our support and guidance for nursing cares that we have for our wandering patients with delirium or dementia also support people who are recovering from a stimulant intoxication, trying to ensure that there's a calm, quiet place, being prepared to use medications orally, and if not orally, IV or IM, to help people rest and sleep, and then getting conversations in there about what's next. Do you need help with finding shelter? Where is the next safe place for you? We use lorazepam, benzodiazepines to treat agitation. And to be honest, a lot of our patients have that co-occurring schizophrenia, maybe it's a mania, bipolar issue on top of a methamphetamine use pattern or cocaine use pattern. And we have adopted a principle that regardless of the etiology of psychosis, it is useful to add an antipsychotic, which kind of is different than the history of treatment pattern that we saw with our psychiatrist team members who really want to, have a time when somebody abstains from the stimulants so that they can diagnose a clear schizophrenia underneath everything. What we know as treatment team in this acute moment is that psychosis really from almost any etiology, whether it is from a stimulant intoxication, stimulant use disorder, or an underlying behavioral health issue, will respond well to antipsychotics and will help people get to where they need to go. The difference is how long in the outpatient setting does somebody need to continue these antipsychotics. So I am, having those conversations at an upper level between our emergency physicians and our psychiatric colleagues and consultants. So we can go forward. Our stimulant withdrawal, I would say often if somebody's in length of stay in the ER long enough, you are going to see the stimulant withdrawal, that very somnolent, very tired. And often this happens so abruptly that sometimes we're getting a head CT or an LP to think about things like, is there a co-occurring, encephalopathy that is not just a stimulant withdrawal? I appreciate the aggressive workup of these situations, and when we have a good timeline, and no other red flags and a good physical exam, we can really start to recognize the stimulant withdrawal features and be comfortable treating and supporting that patient through that. A lot of times this also occurs on hospital day too. So you've seen them in the ER, you've done the stabilizing treatment, you've admitted them, now they're in tele, and then they look so different to what they looked like originally that the medicine team is getting that head CT being like, is this person having an acute stroke because they're so tired all of a sudden? So just to have that in mind, again, it's a good conversation to have between your hospital teams and your ER teams about this, recognizing and supporting stimulant withdrawal, and also your mindset of like not missing anything. That's also important. And I think, I'm like, how many times have I seen a head CT without actually addressing the underlying stimulant withdrawal or the stimulant use disorder? So if we go to the cost and the acuity of getting a head CT and it turns out to be meth, that isn't like stop, it's go. Like, how do we help somebody reduce their use of meth so that we're not repeatedly getting a head CT on that patient, next week? We can go to the next slide. In general, there's a couple medications that help people reduce their use of methamphetamines. Now, these are different than how effective buprenorphine is to engage people with opioid use disorder, which feels really different to our colleagues who are starting to care for people with addiction using medications. So there's, 5, 6, 7 different ways to treat long-term methamphetamine use with basically a number needed to treat like maybe 10, 20, 30 people for one person to really have significant reduced use patterns or abstaining patterns for even longer. That is good. Like we do a lot of things in medicine that has, a number needed to treat in 50s and even higher. So I'm not saying don't do this. I'm just saying be mindful that you're not going to see that like 2 hours later, with buprenorphine, you're discharging somebody who looks well when they started looking so horrible. This mirtazapine is shown to reduce cravings in a subset of population. It helps with that dysphoria. It helps with some of the insomnia. And I think it also helps aligning patients and providers with that concept that addiction is a treatable condition. And let's start calling this a medical condition rather than you're making bad choices over and over again. Let's help you into care. We can go to the next slide. Again, this is the graph showing that there is a treatment improvement, but it is not huge. So we can go forward. Just anchor when you're talking about this to your colleagues, right? They're going to feel like, hey, I gave 100 prescriptions for mirtazapine and I'm not sure I did anything. That's okay. Like you're not gonna have that experience necessarily in the ER of I gave 100 prescriptions of mirtazapine and I see 100 people getting better. It might be the downstream providers are picking up that signal of improvement, but it's not going to be as distinctly felt as the buprenorphine is for opioid use disorder. The other options to engage people for medications for stimulant use disorder is bupropion, which I'm just going to call Wellbutrin because it's so hard to keep bupropion separate from buprenorphine. It just, we get mixed up. So Wellbutrin is an activating antidepressant, and we use it for a lot of other things with cravings like overeating sometimes. And the studies have shown a pretty rapid uptaper from 150, 300 to 450 over a day. And what's interesting, I think, in comparison to usual outpatient treatment is that usually in the outpatient, it's a much slower taper. When people have stimulant use disorder, they've kind of already proven themselves to be, stably either unstable, like metastable on activating medications. So it's important to get them to a high dose as quickly as possible. This does treat dysphoria. It also tends to treat, if I'm smoking a lot, other things like this. We can go to our next slide. We have also seen effects of adding bupropion, Wellbutrin to naltrexone, which also tends to increase that signal of less use of stimulants. Naltrexone, again, is that opioid mu receptor blocker that we use sometimes with alcohol use disorder. We use it rarely in opioid use disorder, but it's also shown to kind of reduce cravings for stimulants in addition to almost any gambling, overeating, a lot of different pathways that activate that craving cycle. So these are the options. These are often things that I would say your hospitalist team day 2, day 3, or if you're really engaging your navigators, they're helping people start this in the ER or start this, day next. Go forward. There's a bunch of other things that have been seen. They're harder to do in an acute care setting. Topiramate works both for methamphetamines limited and also for cocaine. But to get to the effective dose, it's a slow taper up. If you start at a high dose, you're causing a lot of like fogginess and like people feeling mentally slow. There's also evidence for long-acting stimulants like Ritalins and things like this. I would say in my acute care setting, I have yet to be able to implement some of these evidence-based treatments because of the optics and politics around them. So we can go forward. The behavioral health support, the psychosocial approaches for treating stimulant use disorder have a much more significant impact than, say, for opioid use disorder. And the gold nugget that I want to highlight here is contingency management, which is really providing rewards for meeting specific measurable targets. This can also, in my head, I'm like, it's the sticker chart you had for cleaning your room. It's, on some levels, it's getting paid to show up for work. So contingency management historically has been parts of, these treatment programs that are in inpatient settings or outpatient settings. We have at LA General started a really low barrier contingency management that's really, you show up in the ER with something related to your stimulants. Welcome to our contingency management program that's available, near to where you live. You can walk in and you generally pee in a cup. If the urine is showing negative for whatever you're focused on, you're eligible for Target gift cards. It's really that straightforward. And again, part of this is inviting people into that welcoming engagement in a community that cares about you. When they show up for contingency management, they're getting not just, monetary rewards, but, good job buddy awards, like communication rewards and engagement. We can address other things. They're like, oh, by the way, my opioids, oh, by the way, my, housing issues, that we can start having those longer and longitudinal conversations with people. So if you haven't already made a partner with a contingency management program, I would encourage you to do so. And this is a recent LA Times article that highlights now that Medi-Cal programs are paying for this service. And it's a really nice service. A lot of times it's integrated into primary care settings or in ECM, enhanced care management programs. And I would also say that our program is very low cost. I'm running it with a community health navigator, and we're bulk purchasing commercial urine toxicology cups that are not that expensive, less than $10 a cup. And our rewards again are, while it can be up to, I think, a $200 bonus prize, that's like a 1 chance in 500. Most people are getting a much smaller amount. So when people think about building these programs, they're like, oh my God, it's going to be $600 times all the people who use meth in my community. That's an insane amount of money. It really is a lot less. It turns out a lot of people, even when we invite 100 people, I would say, 20 show up, and then, over the time, it's not that 20 sticking with the program every day. So they're coming, they're going, and we're re-engaging in care. So it is possible to start a program from your ER setting. One of the things we also want to say is we do a lot of conversating around urine toxicologies and how they can be really toxic to our medical healthcare professionals and our helping professionals. So a lot of times, in the clearest case is mom who gives birth in a medical setting in the hospital, and then her baby tests positive for a substance, or she tests positive for a substance. There's often in our settings somebody in that care community, whether it's a nurse or a social worker, who has the fixed false health belief that they have to report that to DCFS. In California, that is not the law. The law is you should assess for needs and help that family meet needs. There are a lot of unintended consequences of urine toxicology. So when I'm talking about contingency management with the urine toxicology cups, I'm not talking about putting 100 urine toxicology tests into the medical system. This is a community program, and we're using commercially available products. So we're not making medical decisions. That's why it's so low cost for us. And I think it's more, or how do I say it, less risk of legal harm or less risk of family separation harm for our patients who are not getting those urine toxicology results in their medical records. We can go to the next one.
Thank you so much. Thinking back to what we talked about at the beginning of this lecture, we have to find ways to empathetically explore each patient's substance use and find ways to help them based on where they are at in their specific pattern of use. And it makes me think about something that's extremely common about what happens when our patients use more than one substance. How do these like potential treatments for stimulants fit into this picture? For example, like can I give bup for opioid use disorder and naltrexone for AUD? Reb, can you walk me through this?
Yeah, I would love to, because in my community, you don't get to choose one substance. My patients that their substance of choice is methamphetamine nearly universally are showing up positive as well for fentanyl use, just because you don't get a choice. Rock meth or, rock form is less likely to be contaminated, but I've totally seen it. And so the combos are the rule in my world. And so, yeah, let's talk about that, because as you've heard, some of these medications have some crossover. So, with stimulants, and thank you so much, Rebecca, mirtazapine was mentioned, Wellbutrin was mentioned, naltrexone was mentioned. Those are some of the options that we have acutely to use for stimulants. Obviously, for opioids, thank goodness we have such great treatment with buprenorphine and with methadone. And so that's, something that we definitely need to capitalize on, because the risk of death with opiate exposure is so high. We want to really make sure that we're capitalizing on those great treatments that we have for opiate use disorder. But then if you also consider alcohol use disorder, naltrexone was mentioned there, and then as well we have gabapentin. So for everything, let's kind of mix and match a little bit and talk about some examples. Next slide, please. All right, and so here's kind of that first case, which we'll talk about initially, is someone who's using stimulants who also has alcohol use disorder. I have a number of these patients, and to Rebecca's point, contingency management is such a huge part of this. The gift card is part of it, and that, hey, let me help you. Let's reach you into this community and let's really work with you is a big part of it as well. So, but talking about the medication specifically, you've got a patient that's using stimulants and they drink alcohol. Maybe they also use tobacco products, right, or nicotine products. So naltrexone, as you can see, is listed for both. The dosing is a little different, but getting that medication started, you can actually help with the stimulant use disorder and the alcohol use disorder. And then Wellbutrin, as we talked about for stimulant use disorder, you can also use that for tobacco use disorder. So this is that time to kind of mention to your patient, and whether you're comfortable in your setting, starting medicines or at least addressing them with them, these are some ways you can encourage them that there is help for their use disorder. And then obviously, we use a lot of gabapentin and alcohol use disorder, and I'm seeing a lot of my patients with stimulant use disorder have some benefit with that in addition. So kind of mixing and matching. All right, let's hit the next kind of combo, and that's our stimulants and opioids. And as I said, in my community, that's the norm. That's what we have exposure to at this time. And so the reality, as I mentioned on those opioids, we actually have awesome treatment that keeps people alive. And so I really maximize my treatment for opioid use disorder, specifically with buprenorphine. And specifically, if I can get a patient on Sublocade, it's a win all around. What I'm finding, and this is more anecdote, these are my patients, is that as I get their opioid use disorder stabilized, the stimulant use disorder stabilizes as well. And is that just because they're connected to treatment? Is that because they're having less craving for what they were using because they don't further crave the opioids? I don't clearly know, but really capitalizing on your opioid use disorder treatment is going to benefit the patient as far as saving their life. But in addition, you'll find some signal that it can help their stimulant use disorder as well. And then the mirtazapine, I'm finding that a lot of my patients are needing something that helps with their sleep and kind of helps them regulate that. And these can be used nicely in combination. So really maximize your treatment for opioid use disorder and consider adding in mirtazapine. Naltrexone is a little harder, obviously, because, for opioid use disorder, that is not really the standard of care right now. And so it's something I'm not using for my patients. I'm definitely capitalizing on the opioid use disorder treatment with buprenorphine specifically. All right, so there's some of our combos. And then next slide, please. Like I said, this is the standard. this is what I'm doing all day now, is realizing that these are together and addressing them as such. And so maximizing your buprenorphine treatment. Here's the kicker though, when someone is being started on buprenorphine and say they become more agitated or they seem to be going into precipitated withdrawal, well, are we uncovering their methamphetamines because the opioids were kind of more sedating or calming in that situation? Like what is the circumstance? Are we dealing with now with meth withdrawal and opiate withdrawal, right? Because you've got to consider the acute intoxication state and the withdrawal state for both in these combos. Well, we all know how to treat precipitated withdrawal, if that's what it is, and the treatment here is similar. So truly maximize your buprenorphine, take that off the list. And then in addition, you may need to use some of your adjunct therapies. So benzodiazepines, please don't start them chronically, please, please, please never. But a few doses of Ativan, as a benzodiazepine to kind of calm things down from potential stimulant activation while someone's engaging with induction for buprenorphine, you may need to do that. We do at times need to use some of our antipsychotics in this circumstance, right? Because you don't know what you're uncovering and what you're finding. Ketamine has been used as well in this situation. And then obviously your normal supportive care. We talked about rhabdo, we talked about dehydration. You really want to capitalize on all of the treatments that you have for this patient. And we don't know, and there's no way clearly to know how much is withdrawal, how much is activation, how much is acute intoxication or poisoning. So we want to consider all of that while we use these adjunct therapies. They may need to be admitted. I mean, they may. This is a complex chemistry that's happening in our patients, and that's how I describe it to my patients. But I think openly talking about that, making sure they feel supported is really critical to getting patients through it. So on our next slide, there's one other thing I forgot to mention, and that's the underlying mental health issues. So we may be dealing with opiates and stimulants and untreated depression, anxiety, schizophrenia. So being very mindful, these patients have suffered a lot to get to where they are right now. And we're going to need to address, and maybe not in that immediate setting, but we're going to need to address all of these to get them the care and the treatment that they need. So it does take a lot of coordination, which is why we are tremendously advocating for our substance use navigators to help us with this, but kind of pulling it all together into the polysubstance use, I think that kind of hits it. Next slide, please.
Thank you so much. And before we wrap up, Rebecca, can you talk to me a little bit more about harm reduction for folks with stimulant use disorder? What does it look like for this population to live well?
Thank you so much. I often use the phrase, we want to provide you wellness supplies and information so that we can have healthy, future with you and enjoy your company for as long as possible. So in the chat, we had a couple of conversations about what if a patient has discrepancy between some objective findings like the urine tox report and their self-narration to you of what's going on. Like, I don't use those drugs. I don't know what you're talking about. And that's okay. This is where the harm reduction or the wellness principles come into effect, right? So it is important to offer these even when somebody isn't necessarily ready, quote, for treatment, or they're not necessarily disclosing something to you. And in particular, one of the things that we want to ensure is that our community is aware that fentanyl is everywhere. So more and more and more times do I see people with an opioid overdose event where they disclose to me I didn't use any opioids. I'm pretty sure I only used insert substance here, right? I've even had people tell me, I think I only used cannabis. I only used weed. I'm not sure. So it's important that we provide overdose support, right? So naloxone for everyone. Overdose prevention includes certain behavioral changes. When you're having recurrent opioid overdose events with somebody who's using lots of stimulants, consider that long-acting naltrexone, or perhaps consider the buprenorphine to protect against the lethal consequences of another opioid overdose event. And you can definitely start opioid use disorder treatment with buprenorphine at the same time as you're starting our treatments for stimulant use disorder. So we can go forward. These are our fentanyl test strips. I think most of our community now is giving these out in addition to naloxone from our ERs and hospitals and our community sites. They now have xylazine test strips as well. People take a small supply of their own drugs, they mix it with water, they put it on these test strips, and the test then changes based on the presence or absence of fentanyl. There is some false positives and negatives, so it's still important to have that basic universal care of how do you use drugs safely. I wouldn't want somebody to, completely think the risk of overdose harm is zero if this test showed that it was negative. So it's important to use a universal kind of health promotion strategy. Just like we wash our hands with every patient, we want to make sure our patients are aware of what to do to prevent an opioid overdose event and have strategies to use their drugs more safely. So we can go forward. This is naloxone or Narcan. We give it out in vending machines. We want everybody to have it. I've seen high density overdose areas have naloxone taped to trees. It's important that everybody has access to this. And alone, it's not sufficient. Even if everybody had Narcan all the time, we still know there would be health harm from overdose events. So important part of the strategy, not the only strategy alone. It's a lot of things coming together at the same time. Can go forward. One of the things that has helped, and it's been profiled more recently in the media, is the concept of never using drugs alone. There's phone numbers and apps that help people who use drugs have a buddy either available on the phone or available through an app. If they are unresponsive, rescue services will be sent to them. And it's important that our community members know about this and understand why they're going to use it and have access to it. And so, this is a resource that we give. Even if somebody's like, I don't use any drugs, I'm like, that's wonderful. Just in case you know somebody else who has some drugs, here's information that we can all stay safer. So I'm not trying to like catch somebody in a discrepant self-report or really push somebody to have a come to Jesus moment. I just want to give them tools and information in a neutral and respectful way that they can choose to use when they're ready to use them. So this is one of those tools. We can go forward. Whatever route people are using their drugs, there's likely a safer route to do it. So if people are injecting, they can consider smoking. If they are smoking, they can consider orally taking it. So this is the work that I think our community members, our peer health advocates, our substance use navigators really excel at, is explaining in detail how to have safer use practices, how to safer inject, and have supplies available. So I do have supply kits for any route of use possible, and I make those available to my patients, and I want to know what route are you using and how can I help that be safer. And just to consider, like, people will talk about using toilet water to inject with or puddle water to inject with. So even there are little safe steps that people can make in their day-to-day use of drugs that will really prevent some of these infections, the sepsis, the endocarditis, the abscesses we're seeing. And it's important that we have that communication with our patients too and provide them safe supplies. I also ensure that people in our community know where they can go for other services. So yes, the hospital can kind of give you the starter pack of cleaner use things, and you're going to want to engage in the community syringe service supply programs or syringe exchange programs for more information and more engagement. Other universal information is just like, if this is a new product to you or a new drug to you, or even if it's the same old one, start low, go slow. We say that in medicine all the time. It's true also with unregulated drugs in our community members. So we want to make sure that people are kind of testing their drugs and not, slamming as fast as they can all the drugs all the time, so that they can stay alive. And this is true about whatever drug substance somebody is using. So somebody can describe a totally novel substance that I've never heard of. It's, newly invented. And these are the messages I would be giving to them as a universal health, precaution and practice. And to do it naturally and conversationally is, the goal. Can go forward. When we have developed in Los Angeles strategies to use stimulants more safely, it's been so beneficial to have drug users at the table making these resources. Things that I wouldn't naturally think of are, really obvious to somebody who's been using drugs for a long time. So risk reduction includes making sure that you have water if you've been using stimulants for a long time to prevent dehydration and kidney problems, that you have food, that you have a place to sleep that's safe. We're giving everybody that overdose with opioid prevention information, but also overdose with any substance. we're providing those public health screenings, with our community partners in our ER as much and as frequently as possible. We're asking people to avoid mixing novel substances, to use them slower, and to really consider that sexual and reproductive health element. So, asking people right away, do you want to be pregnant this year? Right? Yes, no. If no, how can I help you with that as much as possible? So do you need Depo-Provera? Do you need hormonal contraceptions? Can I hook you up with an IUD? If you want to get pregnant, how can we help you manage your other health conditions so that it's a safer pregnancy? If you are in the public health world in California and across the country hearing about escalating cases of congenital syphilis, babies who contract syphilis from moms who have untreated syphilis, the co-occurring use of stimulants in unhoused population in Los Angeles is one of the biggest risk factors for that. So people are not excited to engage with the healthcare system as it currently exists. They fear being judged. They fear the health harms to them. And so they're not getting prenatal care. They're not getting the testing they need. And they're not getting contraception management at times of presentation to any healthcare setting. So these are the important features. I had the opportunity to review maternal mortality events for Southern California, and so often it's due to things that we could have prevented. Somebody came into the ER, when they were 2 months pregnant and then never followed up again. So just consider, these are really important things that we can do to change lives. And we put PrEP on there, which is also, prevention from exposure for HIV. And also if somebody already has HIV, right, engaging them into quick care. So just to consider all of those things. We have a lovely new access bridge, which is focusing on pregnancy prevention. We have a bridge community that's focusing on public health screenings. These are all available to you, and looking forward to ensuring that is spread further.
Well, this has been absolutely incredible. Thank you so much, ladies. This was a ton of information. We're going to recap some of the highlights for all of you watching today. So we want to ensure low barrier access to medication for addiction treatment at your site. So for folks in acute intoxication, we want to keep them safe, calm, make sure they sleep. If they need antipsychotics, benzos, we can start them on that. If they're in withdrawal, again, we want to support them during that phase. They may also need antipsychotics, and definitely consider benzos and starting mirtazapine. For those with chronic use, again, consider starting mirtazapine. Consider Wellbutrin plus minus naltrexone. Additionally, we want to ensure the smooth connection to outpatient care, so that folks can continue these medications, and definitely, if possible, get them hooked up with a contingency management program. Those are extremely effective. And lastly, we're going to practice harm reduction, we're going to educate our patients and reduce stigma. And in case this was way too fast and you forgot everything we just said, there's good news. This is all available at our website, bridgetotreatment.org. And if you want an even deeper dive into this clinical content, definitely check out the stimulant guides recently published by the American Society of Addiction Medicine, as well as the CDC. And for all of you that don't know, there is a California Bridge Academy. It's an incredible resource. There's 30-minute to 1-hour lectures for doctors, PAs, NPs. It's all free. So please check it out. And a lot of the lectures count toward the DEA 8-hour requirement for education on substance use disorder treatment. And still, if we didn't answer your question, say you have more, we need to support your team or anything else, reach out to us at info@bridgetotreatment.org. We'll definitely get back to you and do our best to support you. So with that, let's see if there are any questions from the chat. I'm going to stop sharing my screen. All right, here are the questions. How can we help our providers who are feeling fatigue on treating folks repeatedly with serious health-related issues due to stimulant use? This was from Christine. How can we help our providers that are just burned out?
That's a good question. I think the concept of radical acceptance, like you don't need to understand everything in that patient's life to just have empathy and align with, people at some point made a rational choice, and substance use disorder is a condition that changes the brain. So what looks like an irrational decision right now, has a brain change, and that's what's going on. Like, we wouldn't ever be like, why is this person still having seizures, right? We would think about brain changes. So I think that's a useful reframe. The other useful reframe is to find the things that you can do. So we're offering some change, right? So many times it's like the dozenth person presenting for this issue with methamphetamines that day. And, up until very recently, people felt like there was nothing to do around this issue. We just spent an hour describing things that you can do. So pick one of them that seems feasible, try implementing it, give people hope, both provider side and patient side and community side. So I think this is a really transformational moment in the care for stimulant use disorder and stimulant use overall.
Awesome. Talk to me about BUP for patients with substance use disorder who do not overtly admit to even having opioid use disorder. So I've heard some patients who use meth noting they feel better when they're on BUP. Why is that? And do you recommend this? We were just talking about this before.
Yeah, I totally recommend it completely. Anybody who feels better on BUP should be on BUP. And I explain to my patients that it's most likely a contamination of the supply. Whether they intend it or not. I totally normalize that because it is normal in my community. And we trial it. I also remind them that the BUP will save their lives. So truly, if you're using meth and you have BUP on board and there's fent in your meth, you are less likely to die with the BUP. So normalizing it, opening it up, and to Rebecca's point, we have something we can offer. And I think in healthcare, that's been really hard for patients with substance use disorder, and that's changed. And so that's how I handle it. My patients acknowledge it. We're up against, we have no idea what's in the supply. So let's keep you safe and keep you alive.
Absolutely. This is more of a question for our navigators about the urine tox screening. For the navigators on the call, many of them are consulted for patients with positive meth testing in particular, but the patient denies use. Gals, what advice do you have for a navigator trying to communicate with a clinician about the inaccuracy and irrelevance of that urine testing?
Yeah, I think we went through some of the conversations that I have, and if somebody is very discrepant, or maybe it is a false positive test, I still am like, in case you know anybody who uses the drugs, which, I think every single person from CEO to, somebody who has no home, no job, and is very socially isolated, know somebody who uses drugs. And so these wellness messages will help keep them alive, help keep their family alive and their community alive. And so I frame it like that for somebody who's like, I don't use drugs. Whether or not I think that they actually do use drugs, or it's a false positive, false negative, it really doesn't matter, because I want to give them information that they can share with somebody else too. So I really try to align with something, and I'll say, it looks like this result is different than what you're describing to me. That's okay. Is it possible that I can share with you some information that can help keep us all safer and provide you with naloxone for our community? So really trying to, reframe that fighting, adversarial relationship and build an alliance is important, because maybe later they disclose something, 2 visits down from here, and just being positive right now will change that direction of care.
Absolutely. I've got one other question. Can you talk about the role of community-based drug checking programs starting up in many of these communities? I think, Reb, you might be involved in this.
Totally involved in this. So we do it a couple different ways. We obviously have fentanyl test strips, xylazine test strips, talk to the patients about it, talk to them goods and bads. But in addition, we were able to get grant funding to get a true narc, which is a handheld device that you can use to test someone's drugs. Do it all the time. My patients will come with me to the hospital, we'll test their drugs. I give them their drugs back because their drugs, not mine. And then they have an idea of what they're using. I remind everyone, no test is perfect. Absolutely not. The true narc, I'm certain it is not able to detect every possible thing in their substances, nor can it be relied on 100%, but at least they can make some more of an informed decision. So that's how I handle it. And then I also have a lot of patients that ask me to test them. And so we'll send urine toxicology screens to a formal lab to say, oh my gosh, you were totally exposed to parafluorofentanyl and acetylfentanyl. And they'll ask me, what does that do to me? I'm like, oh no, because it was never tested in humans. So just having those frank conversations, I find it to be really helpful.
Well, thank you guys so much. That is the end of this webinar. Thank you for everything you guys do to help keep our patients safe, and we will see you next time.